Good afternoon. I'm Dr. Anoop George Alex, professor from CMC Vellore. The topic that I spoke to in this Heart Failure Association meeting was on hyponatremia in heart failure. So, to concise it, I discussed about the prevalence, which is around 25%. Prevalence of hyponatremia in heart failure is 25%. Then I discussed why this is important, because many studies have clearly shown that patients admitted with heart failure and hyponatremia had increased mortality. So, if sodium was less than 125, purely as a result of heart failure, the mortality was much more than a normal heart failure patient, with a 60% increase in mortality if the sodium dipped below 120. So, this is the importance of targeting sodium in a patient or targeting hyponatremia in a patient with heart failure. So, as we understand, there is a systematic approach that we have to take on managing a hyponatremic patient. That is, once we know that sodium is less than 135, you look at the plasma osmolality. The plasma osmolality is less than 285 or more than 285. If it is more than 285, it is a pseudo hyponatremia. It could be due to hypertriglyceridemia, hyperglycemia, presence of ingestion of hyperosmolar dye, gammopathies, etc. If it is hypotonic hyponatremia, then it is broadly again divided as depletional or dilutional hyponatremia. How do you differentiate between the two? Depletional hyponatremia will have a urine osmolality of less than 100 with a urine sodium of less than 50, and dilutional hyponatremia will have a urine osmolality of more than 100. Now, dilutional hyponatremia is the run-of-the-mill heart failure hyponatremic patients that we see: fluid overloaded, extremely congested, easy to identify and treat. But depletional hyponatremia patients may not be fluid overloaded, and if you take a good history, you will understand that the cause for depletion may be due to recurrent vomiting, maybe due to a presence of hypokalemia or hypomagnesemia that is present, or the presence of ingestion of thiazide diuretics or extremely salt restricted diet. And once we understand which bracket the patient falls on, whether it is depletion or dilution, then our management also differ. If it is dilutional hyponatremia, then water restriction, administration of loop diuretics in combination or without acetazolamide, etc., is the mainstay of treatment. While if it is depletional hyponatremia and the patient is symptomatic with a sodium of less than, say, 125 or 120, then you substitute sodium in the form of saline. If it is less than 120 with symptoms, 3% sodium chloride, otherwise 0.9% sodium chloride, with always a target of not more than 10 milliequivalents per day for the fear of osmotic demyelination syndrome. Thus, a systematic way of approaching hyponatremia and understanding by a good history, clinical examination, and interpretation of biochemical results whether the patient is in the bracket of pseudo hyponatremia or hypotonic hyponatremia. If it is hypotonic hyponatremia, whether it is depletional or dilutional, will help us in effectively managing them. Tolvaptan is something which I have spoken about, the vaptans. It may be tolvaptan or conivaptan, which is an aquaretic, which preferentially allows water only to go through the urine, is one of the mainstays, along with the loop diuretics or the acetazolamide or the other correction of hypokalemia and hypermagnesemia that is present. So, vaptans by the SALT 1, the SALT 2 trials, as well as conivaptan, which is the IV form, has shown benefit if it is used in a very controlled way in the setting of hyponatremia. Along with this, withholding acetazolamide and withholding MRAs and increasing the use of ACE inhibitors and ARBs may also help in the treatment of hyponatremia in heart failure setting. Thank you.